Okay, so we're going to go on to, we're a little bit behind, despite saving some time there. So we're now going to go on to Dr. Civitello, who's going to speak to us about percutaneous management of post-MI complications. Andrew, thank you.
Good afternoon. I'd like to start by thanking my friends and colleagues at the University of Texas Houston for, again, putting on another world-class conference. Special thanks to Dr. Jumine. It's a pleasure to attend the conference. It's an honor to be invited to speak. I'm going to use all my time trying to make this work. I don't have any relevant financial disclosures. I will be discussing some off-label indications for a couple of medical devices. There are several things that are very important here that I won't have time to discuss. I have them listed. I'm going to focus on options for percutaneous management of complications in patients that have been evaluated by a multidisciplinary team and found to have prohibitive surgical risk. These are going to be the three complications that we're going to discuss: papillary muscle rupture, ventricular septal defect or rupture, and free wall rupture. Let's start quickly with acute mitral valve regurgitation due to papillary muscle rupture. These patients are going to be presenting typically 3 to 5 days after an acute myocardial infarction. They inevitably present with acute pulmonary edema. About 50% of them are going to develop cardiogenic shock or present with cardiogenic shock. The management for these patients really is surgical valve replacement, repair in a very small subsegment of the patient, and it preferably should be done very quickly. So how do the patients do after mitral valve replacement for this indication? Long term, they do pretty well. So if they get a valve replacement, their 10-year survival is about 60%. Unfortunately, in a large national registry, we see that about half the patients are actually not referred for valve surgery. They're considered too ill. And those patients actually don't do very well at all. So if we try to manage these patients medically, we see a 71% mortality at 30 days. So this has led to a lot of interest in alternative therapies for papillary muscle rupture after an acute MI, specifically focused on transcatheter edge-to-edge mitral valve repair. Now, we know from the Everest trial, we know from the COAPT trial, we know from other studies that patients with transcatheter edge-to-edge mitral valve repair in general do well. Although it's important to remember that in none of these trials were these patients in cardiogenic shock. They had not recently had an acute myocardial infarction, and they certainly had not had a papillary muscle rupture. So it's very difficult to utilize this data to inform our decision in these particular patients. So we really don't have any randomized data. What data do we have? We had an interesting publication that came out last year using the TVT registry, looking at patients that underwent transcatheter edge-to-edge repair in, quote, cardiogenic shock. So these patients had a procedure success rate of about 85%, and in the patients that underwent successful procedures, they had an improved mortality and decreased heart failure admissions. The difficulty is that this is registry data. It's not particularly granular, and there's a lot of debate as to whether or not these patients indeed actually were in cardiogenic shock. So I think that this is hypothesis generating at best. The literature is really cluttered with very enthusiastic descriptions of percutaneous repair of the mitral valve in patients that had papillary muscle rupture. Although I think we have to interpret this with a grain of salt because there's almost certainly a publication bias. In preparation for this talk, the largest single case series that I could find was published last year from the Scripps group. There were 5 patients that underwent percutaneous repair. All 5 had a successful procedure, but only 1 left the hospital alive. So I think that should give us pause. We don't actually have guidelines per se to help guide our management, but the AHA does have a scientific statement with regards to mechanical complications after acute MI, and it addresses this as follows. In select patients with papillary muscle rupture complicated by cardiogenic shock and pump failure with prohibitively high surgical risk, percutaneous mitral valve edge-to-edge repair may be a therapeutic option. So I think that's about the best that we can say. We're going to move on to ventricular septal defect or rupture. These patients are going to present again 3 to 5 days after their MI. Their presentation can range anywhere from a pansystolic murmur that's isolated to complete cardiac collapse. Management for these patients are really going to be sort of bimodal. So we're going to have an initial phase of stabilization, which we try to support them medically, possibly with temporary MCS. We want the infarct to heal, fibrose. We want to have something to sew a surgical repair to or something to anchor a percutaneous repair. And then Ideally, 7 days or more later, they're going to go for definitive surgical or percutaneous closure. So what is the data for the outcomes? Well, we know from the streptokinase days, the thrombolytic days, the medical management, again, is not effective. We know from the STS registry in patients that have undergone surgical repair that it's best if we can do it after 7 days. Again, for the reasons that we just discussed, these patients tend to self-declare themselves and then self-select themselves. The patients that are really critically ill, you have difficulty managing them. They're the ones that end up going to either surgical repair or percutaneous repair early, and they don't do nearly as well. The operative mortality after surgical repair has remained about 40% for the past 2 decades without any real improvement, which has really been an impetus to try to come up with better therapies. We all know, I think, that interventional structural heart disease have undergone multiple refinements over the past several decades. Very experienced operators have adapted techniques originally developed for things like ASD closures to close VSDs, both in stable and unstable patients. This is becoming more and more widely adopted. We see here from 2007 to 2014, the number of patients referred for percutaneous closure increased while the number of patients referred for surgical closure decreased. These are the outcomes. We can see on the right, the medical therapy, again, poor outcomes. If we look at early transcatheter closure versus early surgical closure, they both have a mortality in the mid-50s, but if we look at late catheter closure after 7 days compared to late surgical closure, actually in this data set, the outcomes are actually somewhat better. So interesting hypothesis generating data. This is what the AHA scientific statement addresses this. It again points out that the surgical risk is about 40%. It recommends that we wait at least 7 days, but it also says that percutaneous repair is a viable option for patients that are not considered surgical candidates. Left ventricular free wall rupture is easy. This is catastrophic. Most of these patients probably die before they seek medical care. The others come with complete cardiac collapse with pericardial tamponade. The only treatment for this is surgical. Very poor outcomes with medical therapy. We do not have any percutaneous management options. And if the patient is a surgical candidate, that is the treatment of choice. I'm going to summarize. Patients with papillary muscle rupture, recommended treatment is surgical. There is a possible percutaneous alternative, which is supported really only by case reports. Ventricular septal rupture, the definitive treatment is urgent surgery. We do have a percutaneous option. It's supported by an ever-increasing data set. And free wall rupture, the only viable treatment is urgent surgery, and we do not have a percutaneous option. And I will stop there. Thank you.
So that was a terrific overview. All of this, of course, is observational data, and as you know, there's tremendous bias as to, who will operate and on which patient a surgeon thinks they can get through the operation. And I almost chuckle when I see the scientific council statement saying we recommend waiting to allow for better lesion selection. That means the high-risk patients who are going to die are not going to.
It's the Darwinian approach.
Yeah. So it's
survival of the fittest.
Right, exactly. So I'd be interested in hearing from the panel, whether from science or from your gut, patients with a severe papillary muscle rupture, a severe VSD. If you were to run randomized trials, are the outcomes better by waiting? Okay, perhaps letting the tissue, especially in the VSD situation, getting a little firmer so there's something to sew onto, patch to, et cetera, or should it be as early as possible before you get into a whole hemometabolic, derangements, et cetera?
We heard something fascinating this morning from one of our surgical colleagues saying that in their center they're putting in the 5.5 Impella and for VSD and letting the patients wait a month. And the reason for doing that is because then the myocardium at the septum tends to citricize. And that's always been the thing that has depressed me about the acute repairs is that you put in a device and then 2 or 3 days later the VSD comes back because more myocardium sort of gets, and the surgeons have the same problem. They think they take a large area of myocardium, they sew it, and then there's leaks that occur afterwards. And at least in our center, we're trying to figure out how to support the patients longer. And I've stopped doing acute, within 48-hour VSD repairs, which I think is pointless. Just curious about
what
the
is
group.
everybody?
We've just had to, I think we have to remember, there's no device that actually has been designed to fix the VSD percutaneously. The VSDs occur in different parts of the ventricle, so even if you have one that looks like it might actually match one of the current off-label devices, you still are left with the issue of soft tissue around it, another perforation, the device pulls through. And so, we can certainly try it, but I go to your question, what makes somebody a non-surgical candidate for some of these other issues, not so much for the VSD? And I do agree about supporting a patient as long as you can, and I think our surgeons are moving, as we are moving to that.
In the height of the COVID-19 pandemic, there were a spate of reports of
late VSDs,
complications, right? Yeah. That's almost a unique opportunity to study a sort of a systematic waiting period, right? I mean, nobody was taking these patients, and you kind of took some segment of, some component of selection bias off the table. And I don't know if you've seen either one of you.
It's interesting.
Any data like just plotting out. Obviously, you've got the confounder of a bad COVID-19 infection in the mix as well, but.
I think that's interesting. I haven't seen any of that data, and the problem is that people don't report the entire cohort of patients. They only tend to report, well, here's how the patients did who went to surgery in different periods. They don't talk to you, 40% of the patients who died were on watchful waiting. But I certainly have not seen it broken down by pre versus post-COVID. But it's interesting.
I do have another question for the panels. What is the ideal MCS strategy for support for a patient with a VSD? In theory, in my mind, putting an impella in with a friable tissue can potentially be problematic, especially in a small LV. Is that going to cause any problems with right to left, shunting that's happening at the level of the ventricles? Putting a device in such as a tandem, for example, can potentially, avoid that problem, but then we can have a watch the right ventricular function. So I'm not sure what other centers would do in this scenario, especially if you're doing this watchful wait for a week or two prior to repair.
See, for the acute MRs, I think that it is good to decongest the lungs. So we've gone to LAVA ECMO to really get the LA pressures down. And that makes the surgery a lot easier, a lot more tolerable for the patients. Because I think it's wrong to send a patient in florid pulmonary edema to the operating room. They're just going to have a huge mess after they've gone on a long pump run, and they're going to end up with all sorts of pulmonary complications, and they'll die a pulmonary death rather than a cardiac death. So I think that strategy works. We're still struggling with what the best VSD support strategy is, and we have tried LAVA ECMO, but that's again associated with a substantial risk of long-term bleeding complications and stroke. So not quite settled yet, and it's still early in our 5.5 experience, but I've heard more and more people as I go around the country saying that they're getting very good results with supporting the VSDs with a 5.5 device for a period of time and then operating.
It's a really interesting approach. It certainly is an expensive approach. There's obviously concerns about having the pump in for that long as well. And I think you were raising some of the issues of perhaps paradoxical right to left shunting by unloading the left ventricle for a long period. I don't know if you've seen, I don't know how many patients you've done at your center, if you've seen any strokes.
Very few. No, not from that approach.
So what about low flow ECMella with a well-tailored low flow on the ECMO side? So I think that we have quite some good experience with that. So I think
how
that
long?
That depends, I think, on the history taking. So sometimes it's a small subacute myocardial infarction, so it can be that the pre-hospital phase is already a week or two. So, and then, we would go for at least 2-3 weeks. Yes, absolutely. And that can be done with a low flow ECMella.
We have done a little hybrid. For the acute mitral regurgitation, I think if tandem heart was for something specific, that was one of the best physiological device to unload in severe MR. Right. And hypoxia clears immediately if the patient didn't have pulmonary edema. So for acute MRs, we unload them with tandem and then go to surgery as soon as possible.
Right.
We have done some percutaneous successfully, but very highly selected cases. For VSD, it's always been a difficult. So what lately we have done is we put them in tandem heart. We've not had the experience with the 5.5, which I think is very attractive. Put a tandem heart for about 7 to 10 days. Beyond that becomes very difficult. And we have attempted percutaneous closure. Now, you don't get 100% closure, but you've closed 70-80%. So QPQS from 3:1 has gone to now 1.5:1. Patient is hemodynamically stable. You can take out the tandem heart, stabilize, and then later on, the 4 weeks period, like surgeon was telling in the morning, wait and you go for definitive surgery later. So that way our outcomes, our survivals are around 70%, which is, I think, reasonable.
Well, I think we all agree that the VSD situation is more difficult than the acute MR situation. The acute MR, you know, again, stabilize for usually a day or two, a couple days, decongest the patient, you know, improve their forward perfusion, and then operate on them when they're more stable.
I've tried all sorts of different ways of transcatheter VSD closure. As you said, I think the problem is that these things are muscular VSDs, and they're never big enough to really get a wide sort of closure, and you always end up with some degree of lack of support. And in the ones that we're forced to do acutely, we always put them on some form of support, either ECMO or Impella, because while you're trying to get the catheters through, when you're trying to pull to create the rail, the patients collapse. And the worst problem is when you try to sort of pull on the wire, I think you end up ripping a bigger hole into the septal defect. So I think it's a very treacherous disease, and we really do need some new. There's no one that's really focusing a device. I haven't heard of anybody saying that we're going to make an acute VSD device. It would be great to have. All right. Well, thank you all very much, and I think that we're done for a little early. Give you a little break, and then
we're supposed to break till 2:30, so maybe 2:30, 2:35. We'll stretch it a few minutes. Okay, but thank you, everybody.
Thank you.
All right. Good discussion.